No, we can hear you.
Yeah, okay, so we're off. Okay, so we're going to talk about the SJT. Thank you. And I know we all know that it's not a great exam and it's got a lot of flaws, but now we need to do our best to get the top mark, okay? And so I'll explain a bit about how we're going to do that. As you've probably known, you've booked your exam either in the Pearson View Centre or at home. And last year, of course, quite a few people had to do that because of the very high number of people who had COVID, and we had no vaccine last year. So this year, I think they're quite different. Now, they have included, and I've sent you 2 example questions of a rating question. And the problem with that is I've asked the UKFPO, and if you look at their website, there's no answer key available. And sometimes it's obvious that some things are appropriate and some things are inappropriate, but the somewhat options are a bit like the middle options in the ranking question. So I'll go through those and I'll show you what we did last year, because I've basically taken all the rating questions from that website and I ran them through an algorithm from students, which you will do in the next 2 or 3 weeks. And I'll show you what the likeliest answers are according to this algorithm, okay? But we'll talk about that too. So let's go through the things that I know. Okay, so first of all, the SJT assumes that you have knowledge of the job of an FY1 doctor, and you'll be asked to respond as if you are already an FY1. Okay, so in a clinical setting, you don't need to have, this is what they say, any clinical knowledge, because it's testing things like commitment, coping with pressure, communication, patient focus, and being part of a team. That's what they say, right? And in fact, the questions, if you don't know any medicine, as I discovered by running this, the mock in year 1, that people do just as well as in year 6. So clearly 6 years medical training doesn't change your mark. Okay, that's I've got that data. I've got the year ahead of you. When they were in year 1, we ran the whole thing in year 1, and they all got the same mark 6 years later. Okay, then there's a question: will you get feedback? Is if you ask them, the answer is no. You won't be given any feedback. You will just get your score. And they say it's not possible to provide meaningful feedback beyond the overall score. I think that's true because we can't agree on the right answer. And then they won't give us specific feedback because they want to reuse the exam questions, is basically what they say. So we're going to talk about the format again. We're going to go through some basic knowledge. We're going to think about how we approach the exam on the day. And of course, this is done on the Pearson View, and you now have no control of the order in which you do the question. You just got to go online and go from 1 to the end. You can then go backwards and randomly go about, but you have to do all the questions once before you can redo a question. Okay, so that's a difference to having the choice. We'll go through some things that you must avoid, some pitfalls, and then we'll go through different kinds of questions. First of all, there's quite a lot of questions on consent. There's quite a lot of confidentiality. There's quite a lot of being a professional, patient safety, and then we'll go through a take-home message. Okay. If anyone's got any questions, do put in the chat or ask if you wish. But otherwise, I'm going to keep going. Okay. So as they say on their rubric, it's invigilated and all of you must take it. It was paper-based. It's now online. The paper-based version was 2 hours and 20 minutes. Yes, you can. You can flag questions to go back to. I wouldn't recommend it though, right? Honestly, if you think this is not medicine knowledge, right? This is not one you can work out the answer to. So I really strongly advise you to not think too hard about a question, because you can second guess yourself and then get the wrong answer. What you think is likely to be right is almost always the better option, okay? So what you really want to do is not run out of time, and I'll show you why that's obviously a bad thing. Anyway, a third of the questions now are these new rating questions. And then there's a third ranking and a third 3 of 8, okay? And you practice them, so you know what I'm talking about. And they say there's some live and some pilot questions that don't count, but we don't know which ones they are. Importantly, there's no negative marking, which means you must answer every question and put a tick by every single question, okay? Even a guess, because if you don't put an answer, then you will get it. You'll get 0. If you put anything down, you'll get some marks. And in the ranking questions, just by guessing randomly, you will get 12 out of 20. And I've proven this. For example, the flags question, we've got 14 because you have some clues about that, okay? And then it's basically to see your insight in being an FY1. Now it's not paper-based, it's all online, as you know. Okay, so you need to, as you've practiced, rank 5 options, and you need to decide which the best ones are. And if you get them all right, you will get 20 points. So if the best option is DCEAB, you'll get 20, but this is key, right? If you are terrible, not just random, you deliberately try and kill the patient by doing the best thing worst. And I will say that some of you have made this mistake because you thought 1 was 5 and 5 was 1. And so you got lots of 8s. So there's 3 or 4 students who got lots of 8s because clearly they just misunderstood the rubric, okay? So if you deliberately, if this is the worst thing you possibly do, and you put that as the best, then you will get obviously 0 for D and B. But for E, you'll get a full 4 marks because it's in the right place, and then you'll get 2 and 2. So the minimum possible mark you can get in the ranking question is 8 out of 20, right? And if you guess randomly, you definitely will get 12 on average, okay, if you guess randomly. So what you have to do is focus on the obvious marks, which are getting 1 and 5 correct. If you get 1 in the right place, immediately you're going to get 14, okay? Because you've got 4, and then the others cannot be far enough away to get less, to get, you will get at least 1, 2, or 3 for the other marks. And if you can get 1 and 5 correct, then you're on to 16, whatever you put in the middle, and you might randomly get 20. Most questions are standalone, so you're not ranking first, then second, then third. You're ranking what we've done, what's the most appropriate thing, and what's the least appropriate thing. However, for 2 years out of this whole time, there were some funny questions where they wanted what order you do things in. So that was different, but then that didn't happen after that. Guessing, as I said, gets you 12 out of 20, right? Randomly guessing. Now for the best 3 of 8, okay, it's worth 12 marks, and you can get 4, 8, or 12. Okay, now, although there's only 12 marks per question, this part is more discriminatory because you can get 0, okay? In the first part, as I call it, in the ranking question, you cannot get 0. So in terms of time commitment, this is worth more, okay? You must do these questions because if you've got to read these to get the 12, whereas in the ranking questions, if you're out of time, you don't get through the ranking questions, you must write random numbers down and you'll get 12, okay? That does not work for the 3 of 8. The 3 of 8, you've got to read it carefully. So if you're going to spend time, spend as little time as possible on the ranking questions and spend more time on this bit, because this is the most discriminatory. Now, I don't know about the rating. They haven't told us how many marks rating. I've looked, I've asked them. We don't know how many marks they're worth. The most important thing is don't spend a long time reading the question carefully, because every question that you don't do is 20 marks lost, okay? So the 3 answers in this part work as a package together. So the best 3 things that would go together, and we'll go through examples to explain how this is. It's different from the ranking questions, okay? So for example, you just discussed with one senior. It might be the charge nurse, or it might be a consultant, but you ask one senior about a particular point, okay? There's no point speaking to several people who are on the same ladder, as it were, the same hierarchy. No. So you can't skip, okay? You cannot skip. And I tried doing it. If you have a go on the mock, you'll see that each screen is a question. And so you got to go past, you might as well answer the question because each refresh takes about a second. And so 60 of those is a whole minute. So you have to You have to do it in the order they give it to you. And annoyingly, it's rating first, okay? But what I'm saying is, when you get to the ranking questions, don't think too hard about those. The 5 options, you get 12 marks for guessing, you get 16 for an educated guess, and then it takes a long time. You've got to read each point, and you might get 2 minutes. Now, 2 minutes per question is all you have, right? So if you spend a further 2 minutes to decide whether 3 or 4 is better, you're going to miss a question at the end and lose 20. Right, Liam, do you want to ask a question? It says you've raised your hand according to this. Just unmute.
Sorry about that. I think that was an accident. My bad.
Okay, fine. Okay. So really, whatever you think is the best answer on the first run through is most commonly correct. And when you start arming and ahhing about whether there's some small print change, you are likely, not definitely, but likely to get a less good mark. Okay. There's lots of fudges I've gone on ad nauseum about, but there's something you should know about this. Okay, they plot this graph. Your actual final mark depends on the bottom mark. Now you'll notice, right? You see, if you look very carefully, there is a 0, someone close to 0, right? Okay, and there will always be someone who is 0 and someone who's always 50. Okay, but there are some numbers that are not occupied, and where they set that cutoff is gray, and I'll show you what I mean by that. Right, so there are 1040 points. Okay, this was in the part without rating. There were 20 questions of 12 and 40 questions that were worth 20. Okay, so the total possible score was 1040. Now, supposing in one sitting the top score was 984 and the bottom score was 280, then they calculate your score by having top minus bottom, totally out of your control, and then they put you as a proportion of, that's your mark. If you get 900, they subtract the bottom mark and divide by that, and that gets you 44, okay, out of 50. It's a ratio times 50. Now, if the bottom mark is 350, it makes a huge difference. So I've just plotted what would happen. So here is the top mark's 984, the bottom mark's 280. So if you are that top person, you get 50. If you get 900 out of 1040, you get 44. If you get 890, you get 43, and so on, right? So each 10 points seems to take you down 1 point. Now, if you do the same exercise, but the bottom scorer got 350, there's my formula, okay? The bottom scorer gets 350, then 900 is worth only 43 as a proportion, and 890 is worth only 42. So whoever scores bottom moves the whole cohort. And why is it important? Because they set the cutoff not on the bottom score, because there are some people who might do one question and give up. Those people are not said to be entered. I don't know at what point they say this person's entered, but it is gray. Okay, so my point really is, don't try and work out your mark out of 50, because the math behind that is completely gray, depending on one single person. Let's get back to what we can make a difference to. So let's go through our basic knowledge. So you need to know the hierarchy. Each answer is independent in the ranking questions, but yes. Okay, so let's talk about the medical hierarchy, okay? So basically you start at the bottom with another F1 and you work up until you found someone who knows the answer. And very important are the allied health professionals. That is the physios and the OTs and the pharmacists and so on, okay? They're absolutely crucial to the answers. Then there are GMC principles, which is basically be a good person. That's basically what all the principles are about. There's the role of a junior doctor, that's your role. And then the questions, as I've said 3 times now, are your insight into being an FY1. So let's look at the hierarchy in order. So the first group are other colleagues. Now they know no more than you, okay? They're just friends. So that's important to bear in mind. The next level up are what used to be called SHOs. And in the current rubric, they should be called F2s or core trainees in year 1. Now, there's a difference between those people, right? The F2s are just a bit older and they've done a few more rotations. So the F1s, so you will next year enter 2 years, and you might do, say, obs and gynae, medicine, A&E, psych, peds, okay? 6 things over 2 years. So the F2s are just a bit further on, but at the end of your FY 1 year, you will be registered with the GMC. Until that point, the medical school that you're affiliated with is really responsible for you, or supervisor nowadays. So the F2s are undifferentiated. Now, CTs are not the same, because when you move in, when you've done your 2 years of foundation, you then need to decide what you're going to do in terms of broad group. Okay, and broad group, the way to remember this is you're linked to a royal college, all doctors. Okay, so if there is a royal college, it's a subject. For example, there is a royal college of general practitioners. So you need to decide at F2 if you're going to become a GP and join that college, or you might join the Royal College of Physicians and do medicine, or you might join the Royal College of Surgeons and do surgery. But this is the point at which that happens. So the minute you become a core trainee, you are differentiated. You decided to do a subspecialty, just surgery. So the colleges are medicine, surgery, peds, psych, O&G, and general practice. Okay, so it'll be one of those groups. So you might have a core trainee in obs and gynae. Now that means they know more than you about the patient. So that's the level at which, and core training in general is 2 years. Okay, and in medicine, for example, you might do subgroups of that. So medicine might be 4 months of hematology, 4 months of gastroenterology, 4 months of endocrinology, 4 months of neurology, and so on. These are all subspecialties in medicine. You might be a core training in surgery, in which case you do surgical equivalents. Okay, so those are core trainees, and they will be doing general medicine or general surgery or general practice for 2 years. And then you decide what subspecialty you want to do as a registrar. So the registrars will be a bit more knowledgeable about the subject. For example, they might be registrars in gastroenterology. So if you're on a gastro ward and there's a gastro complication in a patient, the registrar will be the right person to turn to in terms of managing their medical emergency. The core trainees will know about surgery, okay, and the foundations will be more general. Registrars train usually for between 3 and 5 years, depending on their speciality, and then become consultants. Okay, and the consultant is the head of the team and will be a specialist in one subject on that ward. So if there's a clinical need, then you ask the consultant. That he or she is responsible for the patient. Always ask for help. If there's any clues in the question that you don't know what you're doing, seek help, because that's a safe thing to do. Who else can you ask? You can ask the charge nurse or matron or sister for advice about matters on the ward. And really importantly are the allied health professionals. They're really important, in fact. Okay, then there is who to ask for advice. And I'll just tell you what happens. When you qualify, you will be given on your first day, just before August the 1st, you'll be given a clinical supervisor who will be on the ward that you are working on, right? So let's say your job is 4 months of urology, surgical, 4 months of endocrinology, medicine, and 4 months of acute medicine, let's just say, right? It is likely that your clinical supervisor will be a urologist in the first 4 months, not likely, definitely, right, on the ward. So you will have a consultant who's a urologist, and one of them will be your personal clinical supervisor. When you finish urology and move to endo, you will have an endocrinologist who is your CS, CS meaning clinical supervisor. And when you finish that, you move to acute medicine, and it will be an acute medic who will be your clinical supervisor. So they are kind of on the ward most days. You are on the ward every day. They do ward rounds maybe 2 or 3 times a week, and they expect you to know all the patients in their subject. Okay, and they are there to ask for advice. Now, there are other consultants on the ward, so there might be 5 urologists on a 1 in 5, and one of them will be your clinical supervisor who signs you off. So when you've done all the procedures that you need to do, that CS will say, yes, I'm happy that my F1 can do these procedures. And over the course of a year, you've got a number to get through. It's not many, it's much easier than medical school. Then there's the educational supervisor. Now that person stays with you for the whole year. So it is likely that in your first job, you'll be given one person who is both your CS and your ES. And that will, in this case, be a urologist, okay? And that's someone who is generally gets to know you a bit better. So in the first 4 months, it's ideal to be the same. But when you move to your second consultant as a trainee, as an FY1, the educational supervisor will stay the same. So they'll get to know you over the year, and that person signs you off for GMC registration. Okay, so the CS and then the ES is above that when you're asking for help in terms of these exam questions. Okay, so you speak to your clinical or educational supervisor about colleagues if there's some concern, okay? And you might speak to the CS of the colleague or your own CS for advice. Always ask for advice, okay? Snitching does not occur. Advice is important because if your colleague is ill or doing something dangerous, you must think of patient safety first. Okay, in the situation where those things fail, this is unusual, but it could happen. You might have an alcoholic educational supervisor. The next level up is the postgraduate dean, and they supervise education in this region. So for example, there's a postgraduate dean for West London, and they supervise all trainees at the deanery who are supervised as FY1s. You can ask the GMC for impartial advice, and you can ask for security if you feel that you're being attacked. There's not a lot they can do. You only involve the police if someone has broken the law, okay? There's nothing else to get the police in for, but if the law has been broken, then you need to inform the police. I'll just see if there's any things in the chat. No, the postgraduate dean is someone who works at the London deanery. It's a doctor, but they work in the deanery, and they usually work 3 days a week in a hospital, and they spend 2 days being the dean for training. The clinical director is in one hospital and is responsible for usually finance as well as medical care. What if they're planning to break the law and make you aware of it? Yeah, we've got a question of that, okay? That's the kind of time when you want to get the police in. Okay, GMC Principles is pretty straightforward. Each question is as a scenario. As they say, you don't need any clinical knowledge. Now, here's an important line, okay? The right answer is what you should do, not what you would do, okay? And we would do lots of illegal things. We might believe in climate change and want to block the M25. That might be what you would do, but you shouldn't, okay? And the same applies to this exam. So you put down the answer of what you should do, even if it sounds a little bit unfair. It's the right thing to do legally. You've got to obey the law, okay? The law of the land is absolutely paramount in some of these cases. So let's some general areas. We've said this already: commitment, pressure, be a good communicator, including consent and confidentiality, being patient-focused and make sure that the patients are safe, and then being part of a team. So most importantly, I think the most important thing is answering every question. Okay, thank you. Yeah, don't second guess yourself, put down an answer and then move on, okay? That's I think the most, and it's timekeeping, right? In the days when we had the paper answer sheet, people would not complete it because it takes a little while to scribble. Same with the online thing, it's a bit slow, and so you need to give it time. So the most important thing is finish the paper. As I said, you've got note of the order, the first run through, okay? I used to say, do the second part first, and that's because the rating questions were worth 12, but you could get 0, so it was very discriminating. Whereas the ranking questions, you would get 12 by guessing, and 16 by quickly reading it, and 20 if you spent a long time on it. Okay. No, everything is online. The whole thing is online. The paper, there's no paper. There's no paper, okay? And there's between now, you definitely need to do all the 3 mocks. It'll irritate you, some of the answers, but you just need to do them and see what they've written down. So you've done paper A, paper B, and paper C on SurveyMonkey. I'm going to send you the rating questions that they have set up to run through so I can see your answers, and then I'll show you what you've put. And then you can do that paper as well, and definitely practice. There's a video on it. There's some pretty weird things. So you just do that whole paper. Okay, now these are questions that you've done, so I'll just zip through them, but we need to discuss any questions that you have, okay? So this is, I think, a fairly straightforward question. You're an FY on respiratory. Patients become unwell. The registrar says to you, do an arterial blood gas. The patient says, I don't want that, it hurts, right? I don't want a blood gas. And he's got capacity. So what do you do? Now, it hurts, so he doesn't want to do it, but the blood gas might save his life if his CO2 is going up. So A is not a great option, right? I'm not saying it's bad, it's the worst option, but it's not a great option. And B doesn't help really, documenting the notes. Insisting sounds really unpleasant, so that's a bad answer. Ask provider is okay, but look at E. Explain to the patient the need for the investigation. It may be they don't understand. So obviously E goes right to the top. That's easy, right? E is explain it, get some insight, make sure the patient understands. Okay. Then you decide which is the worst option. Now this is where language comes into it. Okay. And I would say that the word insist, okay, this is almost harming the patient aggressively, right, is a bad thing. I'm going to put C at the bottom. And I don't really know where the middle ones are going to be when I first look at it, but I know that C goes at the top, best option, worst option rather, C is the worst option, and E is the best option. And the middle 3 we can discuss, but don't spend too long on it, because by getting C at the bottom and E at the top, you've got 16 points, wherever you put the middle 3. And you can spend another 2 minutes, which is a whole question, getting 16 to 18. You might get 20, but it might not help you because we don't know the right answer really for often the middle 3. And this one, it's a little bit more straightforward. So I think this is the answer that you guys have put, okay? So I've ranked them in color here. So if you put something as the best option, it's green, 1, then blue, then yellow, then gray, and the worst option is dark blue, right? So all of you, in fact, almost all of you have put E as the best. In fact, everyone seems to have. So that nice phrase like explaining has definitely won you all over, because nobody has put it second, third, fourth, or fifth, I can tell. And almost all of you, but not everybody, because a small number have put it 4th, okay? And that small number have put, except they just want to do it and put it 5th. But most of us agree that the word insist really is a bad word, okay? And that's why we've all chosen to put it at the bottom. And I think this is why this language is so important. It's actually testing English. And that's why most people get the same mark and a few people might disagree. Okay, so this is a very typical example. So we all agree that explaining is good, insisting is bad. And then what you have done, ask for advice, you have mostly put 2nd. You put write in the notes is refused 3rd. You put accept he doesn't want to do it and don't pursue it 4th, because that's pretty bad, but not as bad as insisting. Okay, good. It's being recorded, yeah. And I will send you all a link if you want. Okay, so so that's clear, because most of us agree to, I think this is fairly not very argumentative, but notice again, the middle 2, there's a bit of grayness, yeah? There's orange here, which should be here. So we don't all agree that the registrar advice is better than documenting the notes. And who knows really, right? Honestly, it's tricky, but I'm going with majority. And I've done this now for about 15 years. I've got data like this, and it's always the same, okay? So we all agree that E, explaining is a good thing, insisting is a bad thing, and the middle 3, we're going to go for get some advice, pretty good. Document that he's refused, that sounds a bit worse. B, accept one, not put it further, dangerous. Okay, that's really quite bad. And then C is last. You have no reason to believe he's not got, sorry, you have no reason.
I misread, sorry.
You have no reason to believe he's not got COVID. So basically he's sensible and doesn't want a blood test, and who would blame him? Yeah. Okay. So you assume capacity. Now you might have a question which does in fact do what Mary's saying, that he might be unable to consent, and then you must always remember to get capacity. Now here's an important thing: to get capacity, any doctor can assess capacity, right? And this is what you need to do. You can check the patient can hear what you're saying, can understand it or process it, and then retain it for long enough to ask them again if they remember what you've said, and then can tell you about what they want. And if they can do those 5 things, they have capacity. Who consents the patient? If the patient does not have capacity, supposing the patient doesn't know what's going on, let's say they've got dementia, the person who decides is you. Okay, the GMC and the Parliament have given doctors complete power, okay, to do the right thing, because we have nothing to gain by doing the wrong thing. So the system says, if the patient doesn't know what's going on, you can decide to do anything and the law will support you. Okay, that is the current law. So we're in a really good position. So if you think this patient should not have CPAP, and you write down this patient is not eligible for CPAP, then they won't get it. Okay, and the law will say if the patient dies, that we decide in the patient's best interest. In other words, we are deciding for the patient because the patient can't decide for themselves. Now, who else do you ask? You can ask the family. Now, there is a problem because the family do have something to gain. For example, and this sounds terrible, but I'm going to say it, and that is inheritance. So if you have somebody who will inherit a house when their father dies, there is a conflict of interest, okay? Whereas you will not get a house. The other thing is the word power of attorney, and that's confusing because there are 2 types. The power of attorney is usually something that someone gives you for a particular thing. So for example, if I want to sell my house and I'm not in the country and I need it sold really quickly, I can give one of my family members, my wife or son or somebody, my power of attorney, or even someone more distant or a non-relative to sell my house. They can do nothing else, okay? So I sign a thing saying, I declare that Mr. X has all the authority on all the financial affairs with my house. That does not apply to health or anything else. Now there's one variant of that, and there's this thing called the lasting power of attorney, the LPA. And what that involves is me, when I'm getting my terminal neuro event, when I'm thinking I might become demented, but I'm not demented yet, okay, but if I'm diagnosed as at risk, I might decide to sign an LPA. Now, to do that, it's a 12-page document and a psych assessment of me to agree to hand over the power to control my ventilator to somebody else. And if I sign an LPA, then effectively that person becomes me when I am unable to consent. Okay, so then you can ask them to consent. That's a very unusual thing, but it does exist, and it is used in patients who've got degenerative neuroconditions, like Huntington's, for example. There are patients who think, right, I'm going to sign one of these. You only sign it to someone who really trusts, because they can turn off your ventilator. Okay, that is basic. It's when they say off the ventilator, it's like me saying I want the ventilator turned off. Okay, so it's a really strong thing, and you must be very careful as a patient when you use it. But if you're a doctor and someone has an LPA, then that person is like the patient and can make decisions. If they have a power of attorney, not an LPA, they cannot do that, okay? If they have a power of attorney, you, the doctor, decides. The team, you ask for your senior advice, but you decide what the right thing to do for the patient. Okay. So this is a really tricky, tricky one. How do you know if someone has an LPA? Yes, it's obvious in their notes, and the family will come along and say, I have an LPA, and you want to read it, okay? It's a 12-page document, and it declares at the end, I consent to my wife being my last power of attorney, and it's got a whole paragraph saying, basically, she is me. Okay, very powerful thing. And the patient, the family member will come along and say, I've got one. It's very obvious. It's happened to me, and it's very helpful. Okay, so now we get to some difficult questions, right? So you're at FY1 on pediatrics, and you're asked to see 14-year-old Billy Jones. He has septic arthritis. Now, you know this knowledge, they say you don't need it, but you do have knowledge. Septic arthritis is sepsis and will kill you if you don't treat it aggressively. And the consultant has asked you to prescribe intravenous antibiotics. Okay, this is life-saving. That's the knowledge bit that they say you don't need, but I'm telling you that anyway. Billy's parents are in agreement, but Billy is refusing the treatment. He doesn't want to stay in hospital. Obviously, he doesn't want to have a needle, poor chap. Okay, so what are the options? Go ahead with treatment is obviously a really important thing to do. This is a 3 of 8 question, right? So the parents want it, the consultant wants it, you want it, it's the right thing to do. A is obviously the thing to do, okay? But it is quite nice to be sympathetic to Billy and say, look, it's really important for you to have it, so B sounds good. And if he's being really resistant, you call it consultant C. So A, B, and C all sound good. D, terrible, yeah? Because if you don't give him IV antibiotics, he's going to die of sepsis. So that's not acceptable. Okay, it's not reasonable to tell the family you have a conflab and then decide. So E sounds pretty hopeless. F is quite controversial. Assess Billy's capacity to refuse treatment. Now, people say that's important, but it's not as important as A, B, or C. Right, and I'll show you why. And then discussing it is unhelpful. And oral does not work for septic arthritis. That is a bit of knowledge that you have. Okay, oral is not sufficient. That he will go septic and come back. And that's what you put. This is upside down. So A is at the bottom, B, C. So most of you, 300 of you put B, have put A and C. Right? Yes, A, B, and C. I did see there's a little blip here, and last year I had a very enthusiastic student who emailed me about how unhappy he was with their answer, because he said you must assess Billy's capacity. He sent me this. Surely one should assess the young person's capacity before making a decision such as this, before forcing treatment on him. I'll check the GPC guidance, and they clearly do not state that you should simply give the treatment unless you know they don't have capacity. Okay, and then here's the screenshot of the guidance, okay? If a young person refuses treatment. Now, this was in the case, this applies really for people like, yes, thank you, get it competence, right? For people who either the child wants treatment and the parents refuse, okay? That's one option. And they're basically giving you a little gray thing here saying, you must try and convince him. You can't override a young person. This is exactly what you're saying. This is get it competence for particular things, right? But it says you must carefully out the harms the child and blah, blah, blah. And basically, you can get legal advice if you're really stuck. But you know that what's in the patient's best interest is having the treatment. So for this question, getting consent is not really going to be helpful, okay? Because we all agree what the right treatment is. It is overriding his wishes, yes. So A, B, and C, I want to do. So here is the thing about consenting children, right? If you're 16 and above, and he's 14, right? If they're 16 and above, then they can give consent. They are competent. If they're below, they may be able to. That's Gillick. They cannot refuse treatment in England, okay? And if they don't have capacity, then the parents can consent if it's in their best interests. And if the parents don't agree, then it's your decision. And if you want backup, you get the court involved. And that sounds ridiculous, but no, it's not. You basically ask for the court, for the hospital lawyers, and for this kind, they are down very, very quickly and can help you and get court involvement very quickly. Okay, so it's really quite quick. And then just think about obviously disclosing information to all these different people who need to know about making the decision. So basically, if the consultant says, I want this antibiotic given, then that rules, that's the most dominant thing, okay, because that's going to save a life. And if the family and everyone disagrees, then you get the courts in to make sure that the child survives. If it's an emergency, yes, there is, okay? If it's an emergency, as we'll see in that hematology question in a minute, you do whatever you can to keep them alive, and you go to court. Remember, don't break the law, okay? You can't say, oh, he might die, I'll just break the law. You cannot break the law. So this is a Jehovah's Witness question that causes a lot of unhappiness, okay? So a 10-year-old child with fluctuating consciousness is admitted to following a traffic accident, accompanied by her parents, okay? Now she's 10. Yes, adults can refuse treatment, yes. Okay, the child needs blood. The parents are Jehovah's Witnesses and they don't want blood. What do you do? Now, I have had people email me after we did section C saying you have to do A. You have to do A because it's the right thing to do. That's what I would do. It might be what you would do, but it's not what you should do, okay? You should not break the law, and giving blood to someone who doesn't want it in this situation is assault. So, and you could be charged. And you might say, I don't care if I'm not charged, but it's not what you should do, so it's the wrong answer, okay? And same with B, okay? What you have to do is try and convince them. C, discuss with the parents how important it is, blah, 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 okay? D, IV fluids, keep them going as quick as with IV fluids. That's legal, while you, H, is it H? Yes, get a court order to overrule the parents. Because if the law is on your side, then you're fine. So you can do H pretty damn quickly, okay? Yes, okay. It's assault because you're assaulting the family, right? And let me just tell you an experience I have had. Sometimes under pressure or whatever, Jehovah's Witnesses accept blood or it's given or whatever. And the problem they have, you think, I've done a good job, I've saved a life. And they regret it forever because they believe that now they're going to go to eternal hellfire. And another year of life is not worth it. And it's a sin. And that's a very strongly held belief. And afterwards, they are not thanking you. So, and they will pursue it to the bitter end because you have sent them to hell forever, not just for a year or two, okay? So you mustn't break the law. And so, as we've said here, that's what you put. You have put C, discuss, we agree with that. D, give IV fluids, because that's not going to break the law, and it'll keep them going. And then you get time to get a court order in order to do the right thing. Yes, you have time for a court order. You'll get it within a few hours. And you use saline in the interim, okay? Saline will keep them going. They will, and then if the court agrees, then you can give blood you can cross-match it and have it in the cupboard, but don't give it, okay? Hematologists are very useful if there's an ABO compatibility problem, but it's not ethics, okay? And there is, it turns out, a hospital liaison committee for Jehovah's Witnesses, but that won't help you either. What you have to do is keep the patient alive legally without blood, and then as soon as you've got permission with your consultant, who will push really hard, hopefully, we'll give them some blood. Okay, you have a good point, okay? And that is, we said don't give oral antibiotics because it won't work. And you're saying IV fluids won't work. I suppose it will buy a bit of time. Why is B? Okay, you see, this is the whole point, right? None of them are incorrect or correct. It's just that the best three, this is the problem with the SJT. They're not assessing knowledge, right? B is not wrong, it's just not as good as C, D, H, okay? Actually, overall the parent's decision is breaking the law at the moment because you haven't got a court order to overrule the parents. So that's why it's not legal, okay? So as a group, and I will say this exactly the same as, so we wrote these and the UKFPO, this is a long time ago, gave us all what they thought the right answers were, and they always match. So a majority of people tend to do the right thing, it seems, but not everybody. Okay. So for these questions, you'll get 4, 4, 4. Okay. So if you put CDH, you'll get 12 out of 12. Okay. If you put 1 wrong, you get 8 out of 12. And if you put 3 wrong answers, by this definition, you get 0 out of 12. So it's quite discriminatory. You can get 4, 8, or 12. So it's more discriminatory as a question, and the ranking questions where you can get basically, in all honesty, between 12 and 20. Okay, so this is the problem, right, Omar? And that is that when you start overthinking it, all these things are possible, right? So even in emergency, you cannot treat the child without, yes, correct. Jaya, yes. You cannot break the law without the law on your side, okay? Because if you do so, it doesn't matter if the life is saved, you've broken the law, and therefore you go to jail. How long does a court order take? About 2 hours. Yes, I'm afraid so. The child dies. It's not, luckily you're an F1, so it's the consultant's responsibility. I have witnessed people dying, Jehovah's Witnesses. We had a patient on intensive care. Actually, I will tell you, it takes a lot longer to die than 2 hours, because if you're bleeding, if you stop the bleeding, and the patient's hemoglobin is 40, the patient was then moved to ITU to be ventilated to keep them alive. That's how difficult. We tried everything within the law. We were not allowed to give blood at all, okay? And the patient was started of HB of 40, and then it slowly went down, 30, 20, and then the patient died with an HB of 10 about 3 weeks later on ITU being ventilated, okay? And there was absolutely no way we could give blood. And the court agreed with the family, and that was the end of it, really. But they don't die in hours, okay? Yes, I know. That's what I would do. So SR has said, we've all been told, okay? We've all been told we must save a life, okay? But never break the law, especially in the SJT, okay? So what would happen, right, is you're taking a risk, okay? We're not talking about the SJT now. The SJT, you just do what the law says, okay? Forget about saving lives and being a hero, okay? None of that. We're just doing what the law says, because otherwise you'll get the answer wrong. You can't argue with it, okay? I'm sorry. If a child about to die, do whatever is necessary. Yes, do everything necessary within the law. And usually, you know, if they're dying, it's sepsis, things that everyone does that are within the law. Okay, these are ethics questions, are bizarre in the extreme. I agree. Okay, so best interest now. So that's a really key point. This is a question from Nile. Okay, so when you talk about underage and breaking the law, if you are acting in the patient's best interest, the law will support you, okay? And these are situations that have been tried in court in the past and we've lost, okay? And so we know, we've learned from bitter experience, the law wants us not to do these things, and they've taught us to not break the law. Forget that saving lives. Yes. The law was parents can't refuse life-saving treatment to their children. Well, so that's why you need a court order, but you mustn't jump that step, right? That's why the questions are like this. And so H, getting a court order to overrule the pets are very likely to succeed, and so that's why H is key. No, okay. So appendicitis, okay. Yeah, listen, if the parents will not let me operate on someone who needs an operation, I'll get a court order, okay? Yeah, the get it competence business is a separate thing, and that's got a whole separate bit in the law now, okay? So that particular situation of contraception is within the law, because the law has been changed to cover this area. You need to go to Parliament, okay? If you want to change things, you need to go to Parliament, and you need to get the law changed on Jehovah's Witnesses, and that could happen. You need a petition. Okay. Right. In practicality and not in SJT, would you still transfuse and then apply for order? Okay, I might. Okay. Having done this before and not given blood, I know now that people don't die that quickly. You get ITU, you intubate, ventilate, oxygenate, you actually can run with a very, very low HB for quite a long time. So I'm pretty confident that I won't need to give blood for a while. There will be a point when I'll need to give blood, but there's definitely time to get a court order. Okay, so I would apply for a court order and I would not give blood, because you'd be surprised how low HB can go without actually dying. Okay, I mean 40 sounds scary, doesn't it? But I now have learned that IT keep going with HBs down as low as 20. Yeah. Yes, without adverse consequences. Because amazing how able, with some oxygen, the brain will work. Okay, let's move on. You're working in AAU clerking a patient with a history of paranoid schizophrenia. She tells you that he has bought a gun and going to kill her mother, who's also her next of kin. So you believe she's serious, right? So she's about to kill her mother. So clearly, respecting the patient's confidentiality is a very dangerous thing. You might have a dead mother and you're responsible because you know this fact. So E sounds pretty bad. Seeking advice is a middling, quite good thing. Disclose the information to the police only if the patient consents. Now, they're not consent because, of course, they've got a psych history and they might kill somebody due to these abnormal beliefs. So thinking about detention is important. It doesn't say you will detain the patient, but you can arrange for it by asking for seniors. And then discussing with the police is also a matter of priority because there's the intention to kill somebody. So that's what you put. So seeking advice from someone looks like your most popular answer, and clearly letting mother die is the least good option. That's easy. And in fact, there's quite a lot of uniformity here, isn't there? Because you can see that the second option, arrange for the patient to be detained, after the patient twice, to be detained, comes second. Yeah, so get some advice, detain to prevent dangerous things, get the police involved quickly, disclose information to the police only, so that's negative, yeah, only if the patient consents, that's crazy. And then not to anybody is the most dangerous, so we all agree with that, okay? Let me see what the questions are. Okay, I think you only need one parent to consent, okay? I haven't thought about two parents. If they're having a fight by themselves, that's a separate issue. You need the next of kin to give you consent, whoever that one person is. You see, the problem, Natasha, is you're getting involved in the same way that I don't want you to get involved with the overthinking the middle answers, okay? It's not worth it, okay? We just have to get through it as fast as possible, because what you think first is likely to be right, okay? And you think, is it one parent, two parents? We're getting sidetracked into time wasting, and you've only got 2 hours, 20 minutes to do 70 questions. So 2 minutes. So you read these 5 options, right? That takes about a minute, okay? And you think A, B, C, D, E, that's the best, that's the worst, done. Then you think, oh, wait a minute, shall I detain or ring the police first? You've got 16 already, okay? And you cannot afford 2 minutes getting the middle ones right. It's just not worth it. Okay. Okay, so about confidence, okay? So the GMC says you can effectively break confidentiality if the law says you must. That means not a policeman. That's if the courts say you need to release the information. Obviously, the patient says, all right, that's fine. And if it's in the public interest, which means lots of other people, again, it's a bit like who's had the COVID vaccine kind of thing nowadays. I wonder if they'll put that in this year, I don't know. But if it's in the public interest, then you can break confidence. Involve the police if it's of public interest, right? Like rape, murder, knife or gun crime, and always, of course, call your seniors. If you know she has a gun, no, not really, because if she has a gun, we've already said we're going to detain the patient, aren't we? Yeah, she has got a gun. In fact, you believe she has it, so we definitely all agree. We get some advice and we detain the patient. Okay. Just by the way, you need to get an F2. If to detain a patient, it needs to be someone who's GMC registered, which FY1s aren't. Okay, this is another typical ethics problem that we have a lot of, and that is on acute medicine, a new HIV patient, okay, and he doesn't like the diagnosis, he's struggling to come with a poor person, anxious, and says, don't tell anybody, don't tell my family, my mum and parents mustn't know. What do you do? And so there are various grey things like change his notes a bit to make it a bit vague, like retroviral illness rather than HIV. Explain, see, B is good, isn't it? It's got the word explain. Explain that you work as part of a team so the other doctors will need to know to treat him. Obviously, that's the best answer, isn't it? Yeah, nice bit of do all the right communication bits. So B must be the best answer. Okay, and then eliminate all HIV even though it's clearly madness because he then won't get any treatment. So that must be the worst thing to do. And the other three in the middle. So you put B at the top, C at the bottom, and then we'll argue about where the middle ones go. Let's have a look. So we have put B at the top, explain, eliminate. Almost all of you put that at the bottom. Okay, so top, bottom, let's do the middle one. So next comes the blue. Treat him as you would any other patient. Yeah, that's a neither here nor there unhelpful comment, but it's less bad than, let's see what comes next. Amend the patient notes, which is slightly worse because he might miss something. And then take all the dots up to yourself is better than eliminating or mention, but it's not practical. To detain should be taken into account. Yes, but again, Shiv, we're overthinking the question, right? Just put something down and move on. Is my honest advice. Thinking about too hard, because I don't think the question writers have really each time do the same thing. Because I've noticed that you get different answers for the same question sometimes. Why is amending the list better than taking the bloods yourself? Amending the list. Okay, so you're asking why is, yes, it's a good question, okay, and it's not clear. I don't understand how writing that not illness, yes, it doesn't. Yes, I know, absolutely, it doesn't help, yeah, it doesn't help, but it's better than the slightly worse options. And I can see, I'll just go back one, you can see that there are some people who put blue and grey for amend, second or fourth. But you see that the whole, what you need to do, guys, is get through it quickly, and whatever you put first is more likely right. You'll get some slightly wrong, but if you spend too much time on it and don't finish, you're dead. Okay, that's my point. Okay, it's just impractical. We could argue about it for ages, but I don't want to do that. I want to train you to not look left or right, but just go straight ahead, okay? Just for and then when you finish the SJT, we can go back to normal, right? This is not normal life, right? But we just have to get through this with the highest possible mark. And the highest mark will be got by finishing the exam. Because if you don't finish, some people find it easy time-wise, but if you don't finish, that is what takes you to the bottom. Yes, Matt, possibly. Okay. Don't overthink it. That's my first one to say. Right, you're the FY on the GI ward and looking after Mr. P, a 65-year-old gentleman with alcoholic pancreatitis. Okay, this is quite interesting. So during your shift, the nurse bleeps you and says, Mr. P, son on the phone and wants to speak to a doctor. When you answer the phone, the gentleman on the phone asks questions about Mr. P's condition and how long he's in hospital. Now be careful, right? And I'll put this example, alcoholic pancreatitis, because he might not want his son to know he's drinking alcohol. There's all kinds of things that he might be concerned and he might be fine. So what do you do? Okay, so the right thing to do is not reveal any information, but it sounds a little bit unpleasant. Okay, so he's doing okay. That's probably what I would do, but it's not what I should do. But I probably would say on the phone, yeah, he's okay, but I won't give him lots of information about his pancreas or whatever. But just saying he's okay is divulging some information. okay? Because then that means he's not dead, for example. Obviously, C is terrible, right? You're completely releasing all kinds of information that he might not want him to know. D is obviously the right answer. Confirm the identity of the son on the phone, explain to Mr. B his son's on the phone, and ask permission to disclose. So D comes right at the top, easy, okay? Now the bottom one's a bit tricky because E objectively refused to give any information. That's the right thing to do, but it sounds really unpleasantly done. A is the same thing, but it's a nice way of saying it. So E is obviously a negative way of saying the same thing. So it's all about the language, right? So that's what you've done, right? We all agree confirming the identity on the phone is the right thing. We all agree telling everything is bad. And the middle three, who knows, right? Who knows? But let's see what you put. So second, you put apologize and say you can't reveal. I think that's right. Okay, that's second rather. It's being kind in saying it. And then third and fourth is clearly gray. Because both B and E are quite similar. Saying E is okay, objectively refuse to give information is the right thing to do. So that might come ahead. So clearly, because they're both the same color, there isn't much of a difference. So having got several years of data, okay, I've decided that DAEBC is the legal thing to do. But what I would do isn't the same, it's DAB. I'm going to swap around B and E, okay? And let's look back what that means. I'm going to swap around B and E. So I'm going to say E's okay, right? But the right thing to do is objectively refuse to give any information. So what we should do is DABEC. Sorry, what we should do is DAEBC. And we would do is DABEC. There's one of those is worth 18, the other is worth 20, depending on which way around you put it. And I'm going to quickly move on before anyone can overthink this question, okay? Okay, so if you're asked about a patient wants some information, obviously always confirm the identity of the family member, get consent. Is it okay if I speak to your dad or your mum or your child? I think it's okay to say they're doing okay, but you need to be really careful even with that, because sometimes we really have to see if that person's dead, because that will change the murder trial or whatever. So be careful about saying anything, right? So you should not give any information at all for the SJT, okay? So for example, let's say he's estranged from his son, and his son, he doesn't want his son to know he's okay, right? I know it's unlikely, so be polite, but bear that in mind, okay? Okay, let's be professionals now. You're a surgical FY1, and the consultant is, and this is a way of saying it, expect a lot from his juniors, okay? He's always rude to the other FY1 and shout at her during the ward round for not knowing the patient is well enough, and the FY1 feels they're losing confidence. So there's two FY1s, you and her, and she's having a hard time. And sometimes consultants bully, sometimes consultants are rude to one more than the other, and that is bullying, especially if you are in a favorable position. So bear that in mind. Okay, so let's think about what we're going to do. We can empathize, that's quite nice. We can speak to the ES. We can keep a note of each incident. We can confront the consultant and raise concerns. That sounds a bit dangerous. And advise everyone to speak to their clinical supervisor about the matter. So they're all a bit grey. I think confront definitely loses. So D must be the worst option because that's dangerous. Now what we're going to put top, empathize, take her for a coffee. That sounds like a good thing. And then the ES is quite useful. Keeping a note of the incidents might be useful later on, but it won't help now. Okay, if there's a grievance, then having it all written down is documentary evidence that there's been bullying. So quite often, if you ask for advice, you'll be told by the management to keep notes, but it's not a top option really. So let's see what you guys have put. Hang on. No, sorry. So the consultant isn't the CS, okay? Just to answer Diana's question. So it could be, okay? It could be, in which case you'd raise it to the educational supervisor. But if they are asked the CS, then it's not the same person. So let's say on a ward of 5 consultants, one of them is your clinical supervisor, and that's defined at the start of the time. It'll be a random of there's 5 FY1s maybe. So one of them will get one each. And then one of the consultants is a tricky, unpleasant person who might, in fact, sometimes the hospital decides that consultant X should not have a trainee because they're not trained and they behave badly. Okay, so that is another thing to bear in mind. In general, the educational and clinical supervisors are not bullies, because if they were bullies, they're eliminated from the list of supervisors. They might not be sackable, although they should be, but that's another story. Okay, so sorry, I lost my track there. What was I saying? So empathize comes fourth. The worst option we all agree is confront. That's dangerous, okay? So most of us have gone with advise everyone to speak to a clinical supervisor, a different person, yeah? But that's not uniform. There's quite a lot of people who put that second, okay? And have put advise to her educational supervisor, okay? So in general, you go to clinical, I've got the wrong way around now. Yeah, clinical first and then educational, because they're the next step up. Sorry. Okay, so that's what you've done. You put clinical first and educational second, and then the next thing is grievance, bullying procedures. That would be C. Empathize and have a coffee with her is quite nice, and then obviously confront is terrible. Yes, you see, the truth is the CS is just a consultant on your speciality, and the ES is a consultant who's on the rotation. Okay, so I mean, you know, for educational issues, I'm useless as a urologist, right? But that's not what it's about. It's about supervision and you coping rather than knowledge. Okay, the clinical supervisor is the one with the knowledge of the subject. Yes, thank you. That's a good point. ES is like your personal tutor. Excellent. But it's actually another consultant. Okay, and as I said, in the first 4 months, it'll be the same person. Okay, good. So we've understood. Yeah, that's good. Okay, so we're all tired now, and your colleague has not arrived. It's getting late. It's actually 7 AM and you've just finished the night, 7th night in fact, and it's 7:15 or 8:15 and your colleague's not arrived. What do you do? Bleep starts going off. So be patient as a saint is an option. Hand over to a nurse is not safe because the problems will be medical. Okay, so that's not a good idea. Contact a colleague, find out what's going on. Sounds like a good thing, doesn't it? Communicate. So that's quite good. Find the consultant in the handover room who you know, like me, explain and hand over to him. Okay, I will be honest and say that actually I'm not really very good at SHO tasks, so I wouldn't be very good at putting in lines and things, but I could do that. That's not a terrible option. But communication is going to win, isn't it? So C looks really good. E, inform the day SHO that you're too tired to work and need to go home. Hand over and give them your bleep. Okay, so you're the F1, the day SHO. Now the SHO's got his or her own jobs to do. And they'll generally say, oh, all right then, okay, if they're a nice person, but it will be an issue because that doctor will be in a clinic. And if the bleep goes off, that SHO can't really go to see the problem. So it's not really, I mean, there's not enough doctors in the hospital at the best of times, right? So it's not a fantastic option. So I think we all agree then that find out what's going on and when you're going to come, communicate well, C is going to win, yeah? And then all the others we can be a bit grey about. It's what you put. Oh, we all agree that hiring a nurse is bad, yeah? So we've got 1 and 5 in the right place. So 1, what's going on, communicate. 5, hand over to a nurse. Middle ones doesn't really matter, but let's see what we've got. Get the nice SHO to look after them second, consultant third, patiently waiting is foolish, isn't it? Because nothing, they may not even know they're on call. Okay. Yes, you are the FY1. At the start of the paper, we said you are an FY1. That's to Matilda. Oh, you think, okay, these are not short. Yeah, they're long, aren't they? This is what comes up, honestly. It's and it's quick to read once, but you read twice and you miss a question. Okay, you must not run out of time. That there's no doubt that a few people each year run out of time, and they're basically in the bottom decile because you just missed one question, you lost 20 marks. Because if you guessed them, you'd have got 12 at least. Okay, so let's see what you see. So we all agree then it's C. Let's put the question here. So C comes first, contact, hand of the nurse last, and then the middle three are okay. Yeah, you finish the night shift. So yes, no. So the day SHO has come. What happens is you come at handover at 8, right? And all the FY1s, SHOs are there, and all the new ones have arrived. And your person to hand over to hasn't arrived. The SHOs arrived, but the FY1, the one person you want to hand the bleep over to, is the only one who's not there. Okay. Okay. Okay, this is much nicer now. You've got a £90 check from an old man who's been, sorry, not old, 80-year-old man who's been discharged from your ward after a long inpatient stay. When you arrive on the ward one morning, he says, "Thank you, here's a £90 check for all the care I've received." So what should you do? Accept the gift and don't mention anyone. So you're very grateful for the thought, but you can't accept such gifts. Give it to charity of your choice. Split it with the team. Refuse outright. See, now refusing is the right thing to do, but outright makes it not the best answer. So that takes it down. It's the language that is so important in these questions. Speak to ward sister, thank him for the doctor's mess, or speak to your consultant. Okay. So this is interesting. So one of you is going to keep the money. One. Okay. I don't know who that is, but you're wrong. Okay. You will not pass this exam if you do that. Be great. Say, "I'm grateful. I can't accept it." That's gracious and nice. Please give to charity. That sounds quite good. And speak to the ward sister. The ward sister might spend it on the ward for the other patients, for example. Okay. Refuse the money is a good answer, but the word outright makes it sound rude, which makes it not the best answer. And it's a language thing. Okay. Let's just see what you all think about that. And that's what you all put. So I don't know who it was who's going to accept the gift and not mention it to anyone. Okay, but I think it's pretty straightforward that. So you will think so. Okay, so B, C, and F. No. I mean, I know. Okay, so not legally, not in the SJT. None of us should be accepting. We're all paid by the health service and by the state to do the right thing for the patient, and we shouldn't really accept anything, really. But people do, and most people are genuinely grateful. There's a small risk that when they give you some money, they really want you to write a letter next week saying that they're disabled or something. Okay. Okay, let me tell you what the answer. Here we are. I've got the answers. Okay. So gifts from patients. You can accept small gifts. Okay. Small gifts are not money and have really only emotional value. You must not encourage gifts. Seek advice or help the nurse in charge or person involved in dealing with gifts. So if someone gives you some, you might think the ward can benefit. That's a more ethical way forward than doctors benefiting. We are very overpaid. I know you don't think so, but doctors get plenty of money compared to everybody else in the health service. Okay. Do not accept money. And the other thing you have to do, and this is a legal requirement anyway, is declare the fact you got it. And there's you can declare it on the NHS site. I remember we aren't meant to ask them how to spend money. Why wouldn't you speak to the consultant? You can speak to them all, but let's just see what you all put. Yeah. So say I don't want it. Thank you very much. I'm very grateful. You're such a nice man, but really, I'm already paid by the health service. You know, all kinds of excuses in a nice way to say I'd rather not do it. Speak to sister, because sister will not spend it on the ward or herself, or her team, but on the patients. So I know they might get some other thing that patient, like a TV for the ward. I mean, I've certainly known a ward buy a TV from this kind of gift. Small diamond, yeah, okay, fair enough. I'll put that as the next answer, yeah? Accept a small diamond. Now, drug companies are an issue. I'm extremely against this all generally, but that's my personal view, which I'll take out of this. So you can accept meals and educational things, okay? And by that, things like memory sticks with their logo on it. I don't agree with that, but it's legal. And I mean, I don't think it's possible to accept a gift without being psychologically in debt to the company. That's my problem with it. But legally, you can accept things that are not going to bias you. And that's where I don't agree with the law, because I don't believe you can't be biased. So they say you must not agree to prescribe their drug. If the drug's really good, there won't be reps. You see, that's the point. So you will never see a rep for aspirin or prednisolone or metformin. They just don't exist because the drugs sell themselves, right? And that's the problem, because if there's a rep there, they're telling you something that hasn't been proven. Okay, otherwise they won't need a rep. Why do you need a rep? The drugs that are good get used. Use antibiotics. Not anymore. There were. Do you know what? The hydrocortisone rep. You won't believe it, but there is a rep for a new version of hydrocortisone called Plenadrin, which is really expensive and really useless. And they keep wanting to see me. They don't know what my views are. So there wasn't a hydrocortisone, but when the price went up and these new ones appeared, there are now. Okay, and you can't accept money. Okay, let's move on to patient safety. I know we're getting on a bit, nearly 7 o'clock. Okay, so one of the FYs wears her watch and jewelry every day and does not roll back her sleeves. And we know now that you've got to be bare below the elbows. And what do you do? Report her to infection control sounds good, doesn't it? But it's wrong, because report is a negative thing. We need to do it in a way that will win her round, because she'll say, no, I'm not going to do that. Okay. I'm saying she, but it might be, it's just her jewelry. Yeah, so it is a she. Okay. Discuss it with various people, clinical supervisor, her clinical supervisor, your clinical supervisor. Observe and report if you continue. That means do nothing, and ask the charge nurse what they think. So really great, isn't it? Because there's lots of good and bad things. That's what you put. So you all agree, quite a lot of you agree, casually bring it up to try and bring her into doing it. And most of you agree that reporting her is a bad thing. And the middling ones we can know. Now I'll just show something interesting, because there's a question in the actual exam that is similar but different. And this is the same as happens every year, really. So I'll show you what happened. So discussing it is 4th. Observe, that means do nothing, is 2nd. Ask charge what she thinks is that. There's not a lot in those 3 middle ones. As long as you get 1 and 5 correct, you're going to get 16. Okay. Yes, I agree with you. How is do nothing the second best option? Okay, amazing. Yeah. Now, here we go. Right. So well, this is a question, right? And so you have put ADECB. Now, I got this email from one of your predecessors 3 years ago. I've been going through some of this, a very enthusiastic student, doing it very early in October. Went through the exam question, and you will see these. Okay, these are the ones you're going to do. They're on their website, and you need to do them. And it'll annoy you, but once you've done them, you will have as much experience as anybody else. I came across a question strikingly familiar to the question we discussed at your session last Monday. I was wondering if you would be able to see it online. Now let me look at this. Right. So remember this question, right? Carrying it up is best. Report is worst. And then the middle ones, we all don't agree on, right? Now, here is question 6 in paper 1 that you will do, okay? Just put it out of the way. So it's the same question, right? At the morning briefing, infection control, all hospital staff must roll their sleeves. One of them always has their sleeves down. What do you do? So this is the answers given by the UK FPO. They say B, speak to the one about your observation. And that's a little bit less nice than the one that I had, which was carrying it up with her. But it's saying the same thing really if you look at all the other options, right? The worst option, A, report to infection control. Tell infection control, I'll come back to that, okay, is not coming up with their policy. So these questions, we agree that speaking to the person directly, nicely or however, is a good thing, B, and we agree that infection control is a bad thing. So 1 and 5, we agree on, right? And now look at the middle ones, they're quite interesting, right? So E, discuss it with somebody. Okay, now in my question, we put that 4th, discuss, report if it continues. Okay, discuss it with the supervisor was C. Yeah, that comes 4th. So it's second on this one, right? The bottom line is 1 and 5 are the same. The middle one actually is the same. So it's just 2 and 4 swapped over. So why are 2 and 4 different? Well, it's about the wording, okay? So if we look at D, do not say anything immediately, but monitor the situation over the next few days, okay? So that is the same as observe it for the next few and see what occurs, okay? And option D came second when we did it because of the wording of it, right? So a very small change in the language used in the question changes the answer. No, so they're both right. The wording is different, right? The wording is different. Okay, and then we'll get, as Omar likes doing, we're stuck in the middle options, right? So the way I've worded my question, right? I agree that the middle 3 are a bit grey, but you can still see a gradient, yeah? So continue to observe the situation comes second. Now the wording is different and it makes the actions different as well because it makes one slightly less bad, slightly less negative. Yes, okay, let's look at them carefully, right? We all agree that the top and the bottom answers, A and B, are the same, okay? In this one, it's B and A, okay? We'll take those out. So let's look at what comes third. So they put C third, raise your observation to the nurse in charge on the ward. And if we look back at this one, the middle option is ask the nurse in charge what she thinks, E. So they're the same middle one. So 1, 3, and 5 are the same. So the only ones that are different are 2 and 4, okay? So 2 is the blue, is this one, okay? So in my question, continue to observe over the next few days and report it if it continues, came second. That's doing nothing almost. And 4th was the middle C, discuss it with her clinical supervisor. And this question, they've got to be the other way around. You discuss it with your special trainee second, and 4th is don't do anything immediately, but monitor over the next few days. Now, it's because of the way that they're saying that looks more negative, okay, than this. This is observe and then report it. This is a negative saying the same thing. Don't say anything immediately, but monitor it. You see what I mean? So the wording of the stem makes so both of them are right. And that's why you read it once and you go with what it says. I know it says observe and report, Nikki. I know. But that's the problem with the whole thing. It's when you read it for the first time that the mental image you get of what's going on is the key to what the UK FPO seem to want, okay? So this is the thing, right? It illustrates minor changes in the language. Most of the marks, the best and worst options we all agree on. It's easy, okay? So that's fine. Okay. Most of the marks are best are the same. So it's the middle two that are different, okay? The best option you put down, discuss with doctors. The worst option is go to infection control. in our question, this is the little gray bit, right? I'm going to read it out because we should be clear. Discussing with the CS is similar to reporting to a higher authority, should be fourth. In the SJT question, that option is represented by discussing with your registrar. It's not someone who's any jurisdiction over the person, also junior doctor, and it's basically getting someone who's also junior doctor to have a chat with her in the same way that you could. So it's similar to signifying herself, hence second. No, Helen, there isn't a difference, okay? I'm talking about when you read the question, the image that you get, because when you start thinking about it, it makes no sense, okay? If you think about it too hard, there's no difference. And all these points you're making, okay, are exactly the point I'm trying to make, which is the minute you try and be logical, the whole thing goes out the window, okay? You cannot, this is not a logic exam. I know we've taught you for 6 years to get the right answer by logic, but this is not that. This is a test of English, okay? That's the truth of it. Okay, and then there's two other bits we talk about. I'm going to move on, right? I'm sorry, but I know we're all fed up with this exam, but I'm just telling you how it is, okay? Trying to accurately get the middle 3 marks isn't going to help you. You have to read the whole question. Whatever you think is right is most likely the most marks. Okay. No impact on patient safety. Please answer this question. Which one? Hang on. Why do we ask nurse versus clinical supervisor? It's not above, okay? I think, let me just go, I'll go back to that question, right? It's not that they're above, it's this, okay? It's not above. The middle option was discuss with nurse in charge in both cases. It's 2 and 4 that were swapped over. Now I know that puts registrar in theory above the nurse, but it's not, it's just another person, okay? So let me read this bit here, try to explain it as best as possible, although I accept it as grey. So in our question, discussing with her clinical supervisor is similar to reporting her to higher authority and should be fourth. In the SJT question, that option is represented by discussing with your registrar. This is not someone who's got any jurisdiction over the person, also junior doctor. So basically, getting someone who's the same, who's also junior doctor to have a chat with her. Okay, I'm not putting the nurse ahead of the supervisor. That's not what it's doing. The nurse is in the middle. Option 3 in both questions. I'm going to move on now, okay? Okay, so bad behavior is something that comes up quite a lot, and there's 2 types. So if the patient is safe, then you talk to the person directly in private. It might be embarrassing, and there's no rush with further stages. So you can do indirectly with seniors, and there's time. And then you escalate it as needs be. And what that means by escalate, I mean you start with the registrar, then the clinical supervisor, and you keep looking up. You might go to the dean if it's not sorted, okay? So here's an example. You've noticed on 2 occasions that the other FY1 smells of alcohol. Now sometimes the question is the consultant smells of alcohol, okay? But in this case, the other F1 smells of alcohol, and he's slurring his words on the consultant ward round. So what do you do? Okay. First of all, is there a patient safety issue? Well, there might be. Okay. He needs to not be looking after patients and go on a ward round. Okay. So what are you going to do? Advice with agent advisor is a good thing to do, but we need to move on, right? Urgently. So interrupt the ward round, because otherwise he might do something quite dangerous to a patient. So B sounds a good answer. Okay, and once you've done that, you make the patient safe. So D, I don't think is a good answer, but do nothing immediately is a bit dangerous. And then talking to him is a good thing. Communicating is good. So F looks quite good. And then he needs to go home. So H is a good answer too. I think you will put that. So this is a bit grey, isn't there? But basically, interrupt the ward round is one of the best 3. It's not by a long way though, but that's what you need to do to keep the patient safe. Okay, and then ask him directly been drinking is the winning option. So good, we're communicating well, and say you got to go home is also a safe thing to do. So B, F, G. A is not a bad option, but it's trumped by those three. I think you'd agree. Okay, because you can discuss it at a later date as well, but in this situation, there's some patient safety because the patient might come to harm because there's a drunk FY1 on the ward. Okay, hence B, F, H. Okay, so if there is bad behavior that does have impact on patient safety, you then act directly with the colleague in person and indirectly with the senior. And if it fails, you then escalate. So this is immediate, needs to be sorted out. Now I want to read through this because this is probably the most important page, okay? And it's got some key things, and I'll email you so you have it, okay? But the most important thing you do is finish the paper, okay? Because if you miss one question, you've had it. You're going to lose 20 points straight away, okay? And almost always, whatever you think of first gets you most marks. And thinking hard, and this is why I'm dodging your questions, thinking hard about a question doesn't get you more marks, okay? You might go from 16 to 18 and spend 2 minutes and then not do a question. The ranking questions are not discriminatory, okay? The top and bottom answers are obvious. The middle answers we all guess. So everyone's right bunched up at the top together. That's the problem. You all get the same mark. Top mark 940, bottom mark 930, and there's 7,000 of you in that very narrow gap. And they spread it out from 0 to 50 by saying the bottom mark is 900, the top mark is 1,000. Okay, so it randomizes people by that means there's such a small difference between you. So if you have a quick look through, you'll get quite a lot of 14s, 16s, and 18s, as well as quite a lot of 20s. The middle options you can waste time on, don't waste time on it, okay? You just need to move on to another question because speed is of the essence. And when we complain in the first few years of there's not enough time for all the questions, the UK FBO said, this is time management, part of the key skills that you should have, okay? So really make sure it's a really important attribute for this. So practice it on the timing, practice the timing on the mock exams. There's 3. There's a lot of questions in the UK FBO site. It takes a long time, so you need to do them all. And if you practice all 3 of them, you'll see what they want, and you'll see that you get quite good at guessing the ranking questions with no knowledge. Remember that flags question where we had area of surface area that we'd never seen the flag of, and you all got 14 or 16 or 18 because you didn't put orange first? I mean, that's a good example. The second part, as I've called it, which actually is the 3 of 8, is more dangerous to guess because 3 of 8, if you guess, you most will get 0 or 4. Okay, so don't guess those ones. Yeah, you can't do it in the ordinary. You have to go from start to end. Okay, so practice timing and make sure that you can get through them all. Okay, these are my take-home messages. Basically, the bottom line: finish the paper, read them carefully, but don't spend too long on each question. Okay, you've got to transcribe as you go because you answer online as you go. So that's clearly the thing you have to do. And lastly, can I please ask you to, I know you've all done it actually, haven't you? You've all signed the petition. I'm going to tell you just for a minute about the ethics of that, right? This is on the BMJ back page today. Now I told you, you'll never see an advert for prednisolone or metformin. So lithium carbonate, one of the oldest drugs in psychiatry, advertised. Oh, that's a bit weird. And they say regular for prescription. And there it is. Okay, this is on the back page of the BMJ. It's got 100 tablets, £87 for Camcolit, £87. So I looked out on the BNF, and there's Pradel, the current version, made by Essential Pharma. Okay, same company. Okay, Essential Pharma. So Pradel is dirt cheap, £7.50. Okay, and on the next page, the same drug, lithium carbonate. Okay, £87. So I rang up and I discovered that this company bought the patent to Pradel and they're withdrawing it. They're saying, oh, it's not worth our while making it. We're going to stop making it. And we're all going to be left with having to prescribe Camcolit. Totally unbelievable. Okay, this is in today's BMJ. It's been there for a year, every week. So let's see where we are. 7,400 so far. Anyway, gouging is oh yeah, there. Actually, do you know what you should do? If you want to find it quickly, gouge.co.uk will take you to the links. Okay, if you don't mind, I'll be grateful. Can I put it in the chat? Probably. I'll have a go. Now, good luck for the exam next month. Whatever happens, right, I will say one important thing, right? I know it's geography, but in terms of what you learn in FY1, no, the third one, sorry, Selin, there are three, okay? There are two paper ones, okay, which you read on the screen, and then there's two paper with questions and answers, and then there's a link that you can follow, and it says you can practice this exam, but they don't tell you the answers, okay? But that practice is the third paper. It's definitely there because I've done it myself, okay? And I have downloaded the questions. I will send you those questions on the next SurveyMonkey, and I will then do what I did last year, which is show you I'll show it to you now, actually, if you hang on just a minute. But anyway, what I'm going to say now, hang on, I will show you that's important. So wherever you go as an FY1, right, you are still being trained. It's like a final year medical student, and you will learn different things over the course of the year. But then you'll be registered. It's only after that where you go really matters. So I wouldn't get too stressed about it. But if geography is really important to you, then use that as the thing you choose where you want to go. But actually, it's a waste of time, this SJT, this whole thing, because everyone gets a very, very high mark near the top. So it's slightly out of your control, and we should get rid of the SJT, which is what I'm pushing very hard for. Now, I would need to show you one other thing, okay, which is what I did last year, and that is about, yeah, here we go, UCL and Imperial rate. So what I did was I sent, and I will do this again, right? I took all the questions that were on that ridiculous rating question, okay, and I sent it to all the Imperial and all the UCL students wanted to join in because they had a real struggle in the same way. And I've come up with this, okay? So I got all the students to answer, and I'm going to use them to do this. Is last year, okay? And this is the first question, right? It's an insane question, right? About you're the FY1, you're one of the examiners, and one of the students, your friend Sarah, comes to you and says, what's up in the exam? And so the first question is, tell her what's publicly available. That's highly appropriate, and all the Imperial and UCL students think that, okay? There's a bit more somewhat appropriate with UCL, okay? So I'll send you all this data for your year as well. This is already on the internet. Don't look at it though until you've done the question. This is the first question, right? There's a load of these questions. Telling her that she could be cheating if she tried to find the scenarios beforehand, of course it is. Yes, that's appropriate. Tell her that. I think that's appropriate. I think it's very appropriate, but some of you think it's somewhat appropriate, okay? Explain that it'd be unfair. Of course it's unfair. It's highly appropriate. See, it gets a bit grey, doesn't it? And then here's one that you didn't like. Tell her that she's put you in a difficult position by asking you that, okay? That's, according to Imperial students last year, somewhat appropriate, and you still think it's somewhat inappropriate, okay? Anyway, all of the questions are here, and but I'm going to send you the link to do it, have a go yourself first, and then I'll publish your version as well, okay? Because that's the only way we're going to find out what the best likely right answer is, and we'll take it from there. Let's see any questions here. No, Natasha, this is too much. Already we're doing too much, okay? It's a waste of time. It's detracting you from real medicine, okay? So the 3 practice papers will take you plenty of time, trust me, okay? And you've done A, B, and hopefully C. If you haven't done C, do it. I will send out another round of feedback. And then you've got 3 more papers to do, and you've got these 2 rating ones, which we'll do here, and you can do it there as well. No, I didn't say that. the rating questions are used in the final score. Oh, what I said was 10, there are 10 questions in the paper, which we don't know which ones they are, that are being piloted, okay? But no, you definitely need to do all parts of the paper and do your best. Okay, I'm going to quickly go to gouge.co.uk while you're on. Oh, there it is. There it is. 7467 and counting. I'm going to put this into the chat quickly if I can. Yes, I can. Everyone. Or the other place you can go. Oh no, all your answers will be submitted, okay? All your answers will be submitted when the clock finishes. So listen, you must not run out of time, right? You must not run out of time, because that is that's like failing, okay? That's the thing that kills people. You must finish. Don't even think about not finishing. Great, guys, good luck. Okay, I'm sorry that it's such a rubbish exam, but don't waste time on it. Do it, get a high mark as you will, and then let's move on, okay?
Yes, sir.
Thank you, Prof.